It's a great pleasure for me to be here this evening with you, dear colleagues and dear friends. This is the second part of my lecture, and last week we have spoke about the managing of implant complication in the aesthetic area from a technical point of view. This evening we will consider the biological complication. And everybody of us know that the biological complication are represented by essentially by mucositis and periimplantitis. The key factor in treating the biological complication is the correct diagnosis. And the first thing that I would like to share with you is the concept of mucositis and the concept of periimplantitis. So a mucositis is an infection of the marginal peri-implant tissue without any bone resorption or with very few bone resorption. On the other hand, periimplantitis is an infection with suppuration of peri-implant tissue associated with progressive loss of marginal bone. So it is very important to understand if we are in front of a mucositis or in front of a periimplantitis, and how we can make the correct diagnosis. Only with an X-ray and the probing around the implant. So the correct diagnosis is made by X-ray and by the clinical visit, the clinical approach to the patient. Which is the prevalence of this kind of disease? Around 10% of the implants and 15% of the patient with implants. So this means that it is very important for us to understand how we can treat the mucositis and how we can treat the periimplantitis. If we are in front of a mucositis, the goal will be the detoxification of the contaminated surface of the implant, will be to motivate the patient to have a correct oral hygiene. So we must give to the patient the correct instruction how he can maintain his implant. But from a practical point of view, we have to mechanically remove the plaque and the tartar, and we will see how we can do this, crushing the biofilm inside the pocket. And in almost all cases, we need to apply an antimicrobial agent that could be chlorhexidine, glycine, or oxone. Sometimes we must add additional treatment. So in very few cases, we must add a systemic therapy. And in some cases, we need a connective tissue graft or to use some connective substitute or to use an epithelium connective tissue graft when we have an absence of keratinized mucosa. What is the keratinized mucosa? It consists in a collagen-rich connective tissue that, and it is covered by keratinized epithelium. The keratinized mucosa around dental implant extends from the soft tissue margin to the mucogingival junction, and it includes the free and the attached mucosa. Which are the factors that are able to influence the width of keratinized mucosa around the dental implants? We must have this concept very clear in our mind when we have to treat patients with biological complication, especially in the anterior area of the maxilla. First of all, we must remember that implants located in the maxilla have higher keratinized mucosa than those in the mandible, as it was demonstrated by Langer and Lowe for the teeth. Obviously, when the patient lost the teeth for a periodontic disease, we will have a loss of bone and a loss of soft tissue. So we will have less quantity of keratinized mucosa. And also, when we perform simple or complex procedure of bone augmentation, when we insert our implant, we can reduce the amount of keratinized mucosa around our implant. And sometimes some iatrogenic errors related to the flap design, to the incision, to the implant insertion itself, as we have already seen last week, could determine the possibility to have a very few amount of keratinized mucosa. If we take a look to the literature, to the more ancient literature, but also to the latest studies, we can see that all the authors are split into two different groups. One group consider indispensable the keratinized mucosa, and I am related to this group. But on the other hand, if you take a look to the literature, you can see that some authors consider that keratinized mucosa, at least 2 millimeters around the dental implant, is not needed. And here you can see on the right a study that was published 2 years ago by Christopher Hamele and Daniel Stoma, where they consider also now that the width of keratinized mucosa may not be crucial to maintain peri-implant health tissue in compliant patients. We know that, but I think, dear colleagues, that the question is, from a clinical point of view, which situation you prefer? You prefer to be in the situation on your left, where we have a right central incisor, a smaller section, and a very few amount of keratinized mucosa over the implant after 10 years follow-up, or you will prefer to be in the situation that you see on your right, where we have an implant in the left central incisor and we have a great amount of keratinized mucosa. Obviously, I prefer to stay in the situation of your right. So we can say that keratinized mucosa is more or less like money, better if you have it. Why? Because it will facilitate oral hygiene, the oral hygiene of your patient, and we will see some cases later on where if you have a great amount of keratinized mucosa will be a great advantage for your patient. It will cover maybe the gray color of the implant, but last but not least, you will have a better emergency profile. So we all want to have keratinized mucosa around our implant. So let me show you a case of mucositis that appeared in a patient who had 4 implants inserted in the interforaminal area. And I performed this surgery and this case in 2013. And 3 years later, he had a mucositis around the implant. He lost all the keratinized mucosa. He lost his good oral hygiene attitude. So the first thing that we performed in this case was to convince him to have an increase in his oral hygiene, but we remove all the calculus, all the plaque, and all the biofilm around the implant. But after 1 year, you can see that this situation was not changing. So we decided to perform a surgery in this case and to increase the amount of keratinized mucosa around the implant. And you can see after 1 year, in this case, we have utilized a connective tissue substitute, or we can say better, an epithelium connective tissue substitute. This was the mucograft. And after 1 year of surgery, you can see that the situation is going better. But after 2 years, you can see here on the implant, on the last implant, a great amount of keratinized mucosa. And in this situation, it was easier for the patient to clean the implant. And you can see also on the implant, on the adjacent implant, that we have a good amount of keratinized mucosa, and that the oral hygiene of the patient is increased, is going much better. So let's consider now the treatment of the periimplantitis. And first of all, we must say that we can have different approach to the periimplantitis. And the first approach is probably a non-surgical therapy, especially when we are able to see at the very first beginning the disease. We are able to see the periimplantitis without a great resorption of bone around the implant. In those cases, we can have an approach that is a very non-invasive approach with a surgical therapy, but once non-surgical therapy, sorry, but once again, the goal of this therapy will be the elimination of the opportunistic pathogens associated with infection, and to detoxificate once again the surface of the implant with a mechanical removal of plaque, tartar with correct scaler, and we will see in a very few minutes some special rotating instrument that can help you doing this. So the first approach will be a non-surgical approach. Why? Because if we take a look to the literature, we can see that we can obtain very nice result also with a non-surgical approach. And this is a very important key factor, especially when we consider the anterior region. Because in the anterior region, the treatment of periimplantitis with a surgical approach can determine a resolution of the disease, but can determine a very bad aesthetic result. We will discuss about that later on, but please consider that the first approach to the periimplantitis, in a case that are not severe cases, probably will be very important to solve the problem without any bad aesthetic final result. So if you start with a non-surgical approach, you can relate to this interesting publication that was done 2 years ago by Stefania Fresco, and they analyze 1 year result of non-surgical treatment protocol for periimplantitis. So they treat the patient with the same approach that we have for the mucositis. And then they reevaluate the patient after 6 months. If they can see positive outcomes, which means no further bone loss and a probing depth that was less than 5 millimeters, they can send the patient to a maintenance program and without any surgery. Otherwise, if they have results that are not positive, the patient go go on with a surgical, go on with a treatment, with obviously with a surgical therapy. But the result of this study were very interesting, considering the possibility to decontaminate, to detoxificate the implant surface. And for example, the author analyzed that metal scalers can modify the implant surface and that they can work only in the most superficial area of the threads. They can see that the peak tips that works with ultrasonic and with irrigation are able to leave plastic residues around the implant. So the titanium tips are the ones that are able to clean in the best way the implant without leaving any contamination. And also the using of antimicrobic agent as glycine could be considered in this case. So let me introduce to you this very important rotating instrument that are able to clean all the implant surface. They are produced by the NeoBiotech company and they are titanium made. So they can clean very well the surface of the implant without leaving any residual part, any metallic part over the implant itself. So let me show you one very simple case where I treat the perimplantitis with a non-surgical approach, only with rotating instrument, without raising a flap, with the instrument that I show you just before, and decontaminating the surface, eliminating all the biofilm, and after 1 year, you can see that we have solved the problem of the patient. We had a spontaneous healing of the bone surrounding the implant, which is quite similar to what can happen to the natural teeth when we perform the correct periodontal therapy, the correct periodontal approach in our patient. So it's easy to treat these cases only with a non-surgical approach, and it will be very interesting to use this kind of approach. I will show you later on the using of this kind of approach in the anterior area, because you don't have to raise any flap, you don't have to perform a surgical therapy. But dear colleagues, unfortunately, the perimplantitis cases that we can solve only with this kind of approach are very few. Normally, we have to treat the perimplantitis with a surgical therapy. So we have to perform an osteotomy, an osteoplastic, associated with sometimes an implantoplastic. This represents the effective therapy in blocking or reducing the progression of a perimplantitis disease. And this is a great problem because when we have a healing from an osteotomy, from an osteoplastic, as we can see also in the periodontal healing of our resective surgery, normally we have resection. And so we must be very aware that this method is not recommended in the aesthetic areas. So normally when we have a perimplantitis with a very deep pocket, with the presence of infection around the implant, with two implants that are very adjacent one to each other, we must consider that a non-surgical approach is very difficult in a case like this. So we had to perform a resective surgery, we had to perform an implantoplasty, and you can see here how we have to work from the lingual and from the buccal part and buccal aspect of our implant. The implantoplasty is very important because with this kind of approach, you can clean very well the threads of the implant, and you can almost eliminate all the threads of the implant. But we must consider that this is a very dangerous approach. Why? Because as Andreas Stravopoulos has analyzed in a very interesting review, with this method, you can reduce the amount of titanium of your implant. And especially if you are dealing with very small implant, with implant with reduced diameter, you can have at least at the end of your surgery a very small amount of titanium around your implant. And this fact could lead to the implant fracture. So, dear colleagues, we have treated a lot of cases of periimplantitis with this kind of approach, and we can say that this approach in the posterior area could solve a lot of cases of periimplantitis. But when you have to deal with implants that are very thin, as the one that you can see in this image, if you perform an implantoplasty to clean and to eliminate all the threads or some of the threads of the implant, after some years, you will see the fracture of the implants. So probably you will solve the problem. You will have solved you have solved the problem of the periimplantitis, but you will have another problem: the removal of the implant and the insertion of new implant in this area. So, in my opinion, it is better to solve, when it's possible, the periimplantitis with a decontamination of all the threads without eliminate the threads, without performing an implantoplasty, and when it's possible, to perform a regenerative therapy. So once again, this this rotating instrument, as you can see here, will be very useful in treating your periimplantitis case, because you can clean very well the surface of the implant, although they are rough surface. Obviously, you will combine, and I will show you this therapy, with the use of detoxification, with the use of antimicrobial agent. But with this kind of rotating instrument, as you can see on the right, with the image at the electronic microscope, you can clean very well the surface of the implant. So let's make for you an example with a clinical case. Here in the lower right jaw, we have a periimplantitis in the last implant. And this is a very complex area to be treated with for this kind of surgery, because we are in the deepest part of the mouth, and because sometimes, as in the case that you can see here, the patient did not allow us to remove the bridge, because he was aware that the bridge can break when we remove it. So we were obliged to clean all the surface of the implant only with rotating instrument, both from the buccal and from the lingual part of the implant. And when we are sure that we clean everything well, we can perform the regenerative therapy. But normally, let me show you another case. I will be much better satisfied, I will be happier when I can remove the crown of the patient, because this fact could permit me to clean better the implant surface. So here you can see that this implant was suffering from a periimplantitis. You can see that we have a great amount of connective tissue around the implant, and we have to clean it very well, and it will be easier for me to clean the implant if I am able to remove the crown itself. So on the right, you can see the situation just after removing the granulation tissue, but let me show you on the left how was clean the implant after that I have utilized the rotating instrument. So with the rotating instrument, it was easier to remove all the debris from the implant itself and to decontaminate the surface of the implant after the cleaning here on the right with Oxone. I have started to utilize Oxone to clean the implant when I had periimplantitis 2 or 3 years ago. When I saw this publication that was done on the Journal of Oral Oncology in 2011 by this Italian group of the National Cancer Institute of Milan. They were used to put the Oxone gel over the osteonecrosis of biphosphonate that they treat in the oral region. And they have a lot of patients with osteonecrosis of the jaw with after the therapy with biphosphonate. I know that everybody of us have to deal with this therapy because some of the patients that we treat in our office are used to have biphosphonate for osteoporosis. And this is a gel that you can put around the implant for 3 minutes. Then you can clean everything and you can go on with your therapy. And normally when I have cleaned everything, I prefer to perform a regenerative therapy, not a resective therapy around the implant. And in this case, I put some connective tissue covering the implant because as you can see in this image, the patient has a very few amount of keratinized tissue. So he has a very few thickness of keratinized tissue, and just after 10 years, you can see that how the situation is going better, and you can see that we can expect probably a better amount of keratinized tissue after the healing. But dear colleagues, not always is possible to regenerate around the implant with periimplantitis. And sometimes we have to deal with implants that are failed implants. So we must remove the failed implant from the mouth of the patient. And the removal of this implant will be very easy, for example, for the implant on your left, but for the implant on your right will be not so easy, because sometimes if you have only 4 millimeters of bone around the implant, you must apply force to remove the implant itself because it is well integrated in this area. So to remove this kind of implant will be very useful for you the utilize of the fixture removal kit created by the NeoBiotech, because you will easily handle all the case of implant removal. Also, implant that you have to remove for aesthetic reason that are deeper anchored inside the bone. When you use this fixture removal kit, you must choose the right screw to insert inside the implant, and you have different screw that you can choose for your case in relation to the implant diameter, to the implant branch. But the very important tool of this fixture removal kit is obviously the fixture remover. Inside of the kit, you have different length fixture removers and different diameter fixture remover, because we have to deal with different implant diameter, and obviously you must choose the correct fixture remover to remove easily the implant. This fixture remover works in a very easily way because it goes over the screw that you have already screwed inside the implant with a counterwise clock rotation. And by choosing the correct fixture removal, which is able to capture the neck of the implant that you have removing, by moving with a wrench the fixture remover in a clockwise rotation, you can easily remove the implant, as I did, for example, in this case. But the very important thing is you can treat case where the implant is inserted very deeper into the bone. Here we have a canine with a 15 millimeter long implant, and when that must be removed for a very deep periimplantitis, and also because the implant was not inserted completely into the bone. So it was really well osseointegrated, and we removed it by the use of a fixture removal. But the very interesting thing is that the bone, the remaining bone, was almost intact. So it was very, that you can see from this image, so it was very easy for me to install a new ES2 NeoBiotech fixture just after the previous implant removal. So this is a very important thing. And before we start to analyze the situation in the anterior area, I would like to stress your attention to another important topic, that sometimes when you see bone loss around your implant, extensive bone loss around your implant, this fact is not always correlated to a bacterial periodontitis, but sometimes it can be related to an implant fracture that is not able to see from a clinical or a radiological point of view. For example, in this case, when I tried to remove the implant, I just put the fixture removal, and I saw that there was an implant fracture just down here, and the implant completely remained inside the fixture removal. So this could happen more frequently than you can expect. Let me show you another case. After 7 years of function, this implant in the middle developed a bone resorption. So I said, okay, I have to treat this periimplantitis. I remove the crown, and when we remove the crown, we can understand that the implant neck was fractured. And if we go back to the X-ray, maybe we can see here a fracture line of the implant. So sometimes this kind of situation is related to the fracture of the implant And so the bone resorption is related to this fracture, not to a peri-implantitis. So this fact is very important, because if you treat this case as a peri-implantitis case, it will never heal. You have to remove the implant. So what can we do if we have those kind of biological complication in the aesthetic area? Should we have the same approach than I have demonstrated to you, that I have shown to you in the posterior area, or should we have a different approach in the aesthetic area? Obviously, the answer is that we must consider very well the cases, and we have to deal with a different approach in the aesthetic area. If we have to deal with mucositis, the approach will be the same. So we have to clean the implant without a surgical approach, so with a closed flap approach, and we have to clean and detoxificate as much as we can the implant. And so are very useful to clean the implant, the tools that I have shown you before. And let me show you a very brief video where we have a mucositis in this implant in the lateral incisor, and we can detoxificate the implant by the using of the titanium rotative instrument. This instrument is the eye brush. It works also against the implant, but also against the inner part of the soft tissue. And so you can remove all the debris from your implant by the using of this rotating instrument that are able to clean all the surface. After that, usually I applied some oxone, because as we have seen before, the oxone is very useful in this situation. And you know probably that the oxone is a very antimicrobic agent. So you can apply the oxone for some minutes, and after that you can wash and clean all the surface. And after this treatment, after 1 month from the treatment, you can see that we have a good healing, no resection in the lateral incisor, and a good amount of keratinized mucosa. When we have cases like this, it is the only thing that you can do is to maintain the situation with cleaning the implant surface and without any surgical approach. But the worst situation in the anterior area is the situation when you have to make a surgical approach. Sometimes you are obliged to perform a surgery in the anterior area because of the deep resorption of the bone, because of the amount of suppuration. So you have to perform a surgery. And after the surgery, if everything will go in the right way, you will have very safe tissue, but probably you will have a resorption. A resorption of the bone, a resorption of a contraction of the soft tissue, so you will have a very anesthetic result. And a result like this in the aesthetic area will be a big problem for you and for the patient, because it is very difficult to deal with a situation like this in the anterior area. So let me show you a case of peri-implantitis in this lateral incisor. I have treated this case in 2013, And after 4 years, the patient came in my office with this fistula, with suppuration, with bleeding on probing. So I know that in this case, we must perform a surgical therapy, although we are in the anterior area. And if you have to perform a surgical therapy in this area, you must utilize a minimal invasive approach. And so you can utilize system like a microscope where allow you to work in a very narrow space with a very minimally invasive surgical approach. And with a titanium curette and with the rotating instrument, you remove all the granulation tissue, you clean all the surface of the implant. Obviously, I do not perform any implantoplastic in this area because I am worried about the final aesthetic result. At that time, I was used to apply doxycycline over my implant after the cleaning. You can see here. And after the completely cleaning of the implant, regenerative surgery with some heterologous bone and with a resorbable membrane. And after 2 years, in 2019, we had this kind of situation. We had a small resorption of the papilla, but a good aesthetic result, fortunately. As we said before, sometimes we are not able to maintain our implant, especially if they are particular implant like the monophasic implant that you can see in this image. We have already spoke about those kind of implant last week, and these are called Tramonte screw, were very common 40 years ago in Italy, but you have to deal with this kind of implant, with this kind of perimplantitis. Obviously, it's not possible to you to deal with this situation again, so you have to remove the prosthesis, you have to remove all the implant and to go on again with the cases, inserting, in this case, 6 NeoBiotech implant and the new screwed in prosthesis. Another case, this is a case where we can see a massive periodontitis, and another case where it's not possible to maintain the implant into the mouth of the patient. So in a case like this, once again, we have to remove all the implant and to perform maybe a removable prosthesis before the insertion, once again, of 4 implant ES2 NeoBiotech in the upper jaw and 4 implant in the lower jaw, and to create 2 fixed screwed in prosthesis over the implant. But in the anterior area, the worst situation is when you have perimplantitis and a wrong implant insertion, bad implant insertion. Because in a clinical situation like the ones you see here, probably if I have a correct insertion of the implant, it will be possible for us, it will be possible for me to manage the situation without removing the implant, as I have shown you before, with a microsurgery approach and maybe some bone regeneration without removing the implant itself. But in a case like this, where we have perimplantitis around the implant and we have a wrong implant insertion, it's not possible to maintain the implant itself. So we have studied the case with our technician. This was a complex case from an aesthetic point of view because we have a great number of recession. and we remove the implant with a fixture removal kit, and we wait for the healing with a provisional removable prosthesis. Because from an occlusal point of view, we didn't have space to put a fixed prosthesis, like a Maryland bridge. So after 3 months, we perform a surgery where we insert a new implant, and we perform a bone regeneration. We insert a NeoBiotech ES2 implant, and after 1 year, we insert at least 1 year the provisional restoration, and more after 1 year more the final restoration. And here you can see the situation just a couple of weeks ago. We had a good integration of the new implant. We had a good soft tissue maturation, and also we have solved the resection in the canine. So it was a complex case, but in some cases it's not possible to maintain the implant. We have to remove the implant, although we are in an anterior area. So which will be the take-home message of the managing of this kind of complication in the anterior area? We can understand very easily that those are the worst situation to be treated, because the final result can be perfect from the point of view of the resolution of a periimplantitis, but could be an aesthetic disaster. So try to have the most conservative approach that you can, that is possible. And if a conservative approach is not possible, especially when you have to deal with implants that are inserted in a wrong way, it is better for you to start over again by removing the implant. And we have the possibility to easily remove the implant by the use of the FR, the fixture removal kit from the NeoBiotech company. But the best way to resolve a biological complication, in my opinion, especially in the anterior area, is to avoid them. So could we avoid this kind of complication? Do we have any special guidelines for the patient follow-up? And the answer obviously is yes. If you go to the literature, you can have the correct guidelines, and you can see which probably could be the feasible one in your clinical practice. 5 years ago, I, together with a couple of colleagues, together with my oral hygienist, we analyzed fixture with more than 10 years of follow-up. So we analyzed at least 1,091 fixture in more than 800 patients with a minimum of 10 years follow-up. And we can distinguish 2 different protocols for the patient in my office. We have patient with a healthy periodontum, and we have patient with a history of periodontitis. So after the final prosthesis is set, we go for an oral hygiene follow-up every 6 months with patient with healthy periodontum. And on the other hand, we go for oral hygiene follow-up every 3 months with patient with history of periodontitis. And with this kind of approach, we had a cumulative success rate in more than 800 of patients of 94%, 98.2% cumulative success rate with a patient with healthy periodontum, and 92% cumulative success rate in patient with history of periodontitis, periimplantitis and periodontitis. So which could be the keywords? The keywords is communication between you and the patient, between you and your patient. We really, when we have to deal with patient like this, we can obviously say that the oral hygiene of a patient was really bad, but probably there has been also a problem of communication between the patient and the doctor and the oral hygienist. So when we have to rehabilitate this kind of patient, we must consider that the communication is the key factor if you want to have success in your practice, in your clinical practice. And if you don't want to have patient like this, but you want patient like this one, you must communicate very well with the patient. If you want to check a final rehabilitation like this one that we did years ago, and after 20 years of follow-up is still functioning, is still in good, healthy situation, you must consider that communicate with your patient is the key factor. But you must consider that your job is not an individual job. You are not the guest star of your office, but the final result, the final ideal result is a teamwork. You, your technician, your dental hygienist, your back office, everybody is working with you in your office is important to obtain final good result from an aesthetic and from a functional point of view. So, dear colleagues,